folks can take their seats. So welcome to the Gould Auditorium, which is an appropriate place, of course, for the Gould Lecture. I'm Sarah Shreves. I'm the Alice Sheets Marriott Dean of Libraries here at the University of Utah. And it's wonderful to have you all here for the 2024 William R. and Erlyn J. Gould Lecture on Technology and the Quality of Life. And I'm really pleased to have you here for the lecture today. So today's topic couldn't be more timely. As technology continues to reshape our world, its application in healthcare is transforming patient care and addressing disparities. We are honored to have Dr. Fátima Rodriguez with us, a leader in cardiovascular disease prevention and a trailblazer in using technology to improve heart health, particularly in marginalized communities. Before introducing Dr. Rodriguez, I want to extend a warm welcome and a heartfelt thanks to the Gould family. Your support over the past many years have been instrumental in making this lecture series a success. So I'd like to acknowledge the Gould family and the members of the Gould Advisory Board. So Bill, Gilbert, Wayne, and Andrew Gould. Also Dean Emeritus Richard Brown, just turned Dean Emeritus Richard Brown, Associate Dean Emeritus Gregory Thompson, Mary Hall, Director of the School of Computing, and Jill Winters, Professor at BYU. Your guidance and dedication continue to shape the impact of the lecture series. And in fact, we just had a really energizing board meeting talking about future topics. And I'm coming out of that meeting just really psyched for the next few years of lectures. But please stand and be recognized for your contributions. For those unfamiliar with the history of the Gould Lecture, it began in 1991 with a vision to explore the intersection of technology and the quality of life. And this series has since become a platform for engaging with ideas that bridge disciplines and inspire innovative solutions. And if you can just imagine the range of topics that we've had since 1991, I mean, it's really an incredible series. So thank you again to the Goulds for being part of this and helping us build this lecture series. So this year's lecture focuses on a critical area of healthcare, the use of artificial intelligence in cardiology. Dr. Rodriguez will discuss how AI is being harnessed to detect heart conditions earlier, personalize treatments, and improve patient outcomes, especially in communities that have historically been underserved. Her work not only highlights the potential of AI in transforming healthcare, but also underscores the importance of equity in delivering these advancements. Dr. Rodriguez is an associate professor of medicine and section chief of preventive cardiology at Stanford University. She also serves as associate director of the Center for Digital Health with a focus on health equity. A graduate of Harvard Medical School and of the Harvard School of Public Health, Dr. Rodriguez's expertise in preventive cardiology and her commitment to addressing health disparities has made her a leading voice in the field. Her research group, the Heart Lab, is dedicated to advancing health equity through multidisciplinary collaboration and cutting-edge technology. With that, it's my pleasure to introduce Dr. Fátima Rodriguez as she presents her talk on inclusive innovation, technology for cardiovascular disease prevention.
Thank you so much for that kind introduction. I have no idea how you found me, but I am delighted to be here. And I want a big thank you to the Gould family. You are incredible. It's such a pleasure to get to meet some of you yesterday. And thank you to all the organizers for, again, a wonderful event. I do have an important disclosure before I start. I am a practicing cardiologist. Again, that's not a bad thing, but it does shape everything that I'm going to talk about. Everything that I'm talking about is really rooted in patient care and trying to use technology to advance the care of our patients. I hope we can cover 3 main topics about how technology can advance cardiovascular disease prevention. The first, which is obviously the most interesting, is detecting hidden risk through artificial intelligence. We'll talk about some examples at Stanford. But it's really important that we recall that we have to be inclusive as we try to design our interventions for populations who may not have access to the latest and greatest technology. And then, of course, the hot topic of generative AI in the care delivery. So we'll start talking about detecting hidden risk. So everybody has been touched by heart disease. Heart disease is the leading cause of death for men and women worldwide. And we've made significant advances if we look in the past several decades. And a lot of this is because of technology. We now have cardiac stents, we have new medications, yet there's an ominous uptick in the deaths from heart disease over the past few years. And this is really due to unrecognized heart disease. But one of the reasons that I became a cardiologist, and I'm so passionate about this topic, is that for about 80% of people, heart disease is entirely preventable. And this is by recognizing people who are at high risk early and promptly beginning preventive interventions. So how do we do this? So one way that we assess cardiovascular risk is to think about traditional heart disease risk factors that we're all familiar with: smoking, high cholesterol, diabetes, physical inactivity, obesity. Yet, we can miss a lot of people by just relying on traditional risk factors. So as a cardiologist, I often rely on this tool, which is called a coronary artery calcium scan. So this is a specialized heart CT scan that is timed to the beating heart that can tell us the amount of calcified plaque in the arteries of the heart. There's been a lot of really strong epidemiological data showing that as that number goes up, the risk of heart disease goes up. Again, showing that this is an extremely valuable tool in finding those people who are at high risk. So essentially, the higher that number, the more calcium there is in your heart arteries, the higher your risk of heart disease. But even more important, that risk can be mitigated by starting preventive therapies like statins. So what's the issue? Why don't we do this for everybody? It's a really, really good way to, again, identify those who would benefit the most from prevention. The reality is that these type of CT scans are actually not covered by most insurance companies because there has not been a randomized control trial that shows that they enhance outcomes. There's a small but sizable out-of-pocket cost for these scans, and there's a lot of disparities in who has access to these scans. Not everyone who needs these scans sees me in preventive cardiology clinic at Stanford. Here's some data that, again, that's showing who is actually using coronary artery calcium for risk stratification. Again, in general, the darker blue is the census data and the lighter blue is who's getting the tests. We can see that there's an overrepresentation, again, of white individuals and tends to be underutilized in Black communities, Asian and Hispanic communities who have less access to these kinds of tests. Yet there's an opportunity. People have tests done all the time. Every time you go to the emergency room, following up for a lung nodule. These are non-gated chest CTs, so CT scans done for other reasons other than to assess cardiovascular disease. And these CTs actually contain valuable information about the risk of heart disease. Whereas there's only about 600,000 of the specialized heart scans done a year, nearly 20 million non-gated chest CTs are done a year. So there's an opportunity there. Can we use that data without performing any more tests to identify those at risk? And that's really the idea behind opportunistic screening. So opportunistic screening is to use imaging, again, that has already been done to find something else. And this is different from an incidental finding, which sometimes is a nuisance. And this is where technology can come in. So artificial intelligence can be used to very quickly, very efficiently go through the archives of hundreds and thousands of CT scans to find individuals at risk. That's the innovation. So being at Stanford, there's always young, excited, brilliant people who have an idea and want to start a company. So these are our colleagues from Bunker Hill. These are 2 computer scientists, master students, who had an algorithm. We worked with them to develop, which again, we used paired special scans with the non-special scans. I know I have a lot of engineers in the room. You can talk technical, Andrew, later. You can ask me some questions. But again, here, the gold standard, the ground truth, is the actual gated scan. So this algorithm performed really well, again, in quantifying risk in scans that are not special, scans that have the noise, the artifacts. And again, this could be leveraged across over 20 million CTs a year. When we looked at our own data at Stanford, we found that just like in the special CT scans, these already available CT scans, the number of calcium very reliably predicted heart disease risk. The higher the calcium, the higher the risk of dying from heart disease and stroke. And these individuals had no idea they were at risk. And importantly, these are the populations that, again, I may not see in my prevention clinic. Many women, Asian, Latinx individuals. And again, these individuals who do not have existing heart disease, over half of them had evidence of plaque in their coronary arteries. But this is not about data. So I have Sujana out in the back. She's one of our cardiology fellows, Dr. Bala. She's been part of our research team, and now she's in your university. She knows Doug. So meet Doug. Doug is our patient representative. So Doug, 5 years ago, had a CT scan to follow up on a thyroid nodule, and that CT scan showed severe coronary artery calcification. Doug was not notified. Doug founded a research group, and he was so upset. Why wasn't he notified until 5 years later when he saw cardiologists and had to deal with the consequences of this risk? We have Doug writing papers, writing grants, meeting with us weekly, and this is what Doug has to say. In my case, the system failed to provide the information, preventing me from making healthcare decisions. But he is confident, and this is why he works with us, that technology exists to assist everyone. Accurate, timely care, and that's really the goal. So I will say this, algorithms are awesome. Algorithms are constantly being created. There's an algorithm for everything, especially at Stanford. But that's not the innovation. The innovation is how do we move this algorithm into clinical care, into helping our patients. And we have a series of studies called the Notify studies, where again, we're using this information as an actionable way to get our patients into care. So this is what we did. So at Stanford, we ran through thousands of CT scans in patients without a history of heart disease and identified those that had calcium, as shown here. This was quantified with the artificial intelligence algorithm. And again, in case it wasn't clear, we put this big red circle on it so everybody could see that should not be there. This is your heart. This is a personalized image. We then notified the primary care physician. We said, your patient had had this historical scan, and this is what the letter looks like. We used an artificial intelligence algorithm to identify it. You may want to talk to your patient about reducing their risk through the use of statins as recommended by practice guidelines. That's it. That's the intervention. If we didn't hear anything negative in 2 weeks, again, they know their patients best, then we notified the patient with much patient-friendlier language. People with calcium in their coronary arteries are increased risk of having a heart attack compared with people who don't have calcium. Talk to your doctor about considering starting a statin. And this is what we found. We found that in individuals who were not notified after 6 months, usual care, and again, many of these patients had risk factors, high cholesterol, high blood pressure, only about 7% of them started a statin. But among those who were notified, over 50% started a statin. That is a remarkable effect size. We've done a lot of studies around statins, and much, much more intensive high-touch studies. Again, very impressive. There was also a halo effect. So you're seeing your doctor about talking about heart disease risk factors. Not just your cholesterol is going to improve. You're going to exercise more. Your blood pressure will be better. Your blood sugar will be better. Again, there's so much benefits to engaging in that conversation. And I'm really happy to report that we just did another study, the Notify Extend study, where we looked at the persistence of statin therapy. And in 18 months, the levels of statin use are about 70%. Extremely high, and again, we don't see this with a lot of other much more intensive interventions. We're also now trying to understand the perspectives of our patients and clinicians because again, I'm a cardiologist, my disclosure, I think this is great. Statins are awesome. But there's a lot of questions that remain. How do they feel about having artificial intelligence being used on their medical records? There are certainly patient data use concerns, privacy concerns. What if the patient doesn't have a primary care doctor? What if no one's willing to prescribe them the therapy? How do we balance being effective, yet minimizing patient anxiety? One of our patients told us that they almost dropped dead from the notification. Now, we certainly don't want that. So we've had to find a way to balance this. And then again, we're hosting focus groups with other diverse communities outside of Stanford to say, how do we tailor this message to your particular need? And a big lesson, if you take anything from today, is that there's not a one-size-fits-all. These kind of interventions have to be tailored to the local environment, to the specific patient needs, and there's always going to be a role for a physician or a care provider here. I'm excited that in our preventive cardiology group, which I lead, we are trying to move away from putting all this in the primary care doctor's hands, and we're trying to develop a clinic, a special remote clinic, again, managed largely by algorithms, where we take patients that are high risk, and again, if they don't have access, we can see them in our clinic and start them on appropriate therapy, and not just focusing on cholesterol, but really all their heart disease risk factors, nutrition, anxiety, wellness. And again, this is really only the beginning. We're now looking at fine-tuning the algorithm, Andrew. And here's another CT scan that is done for lung cancer screening. And again, these are even grainier CT scans, so the algorithm has to be improved. But again, patients who are undergoing screening for lung disease, for lung cancer, these are exactly the same kind of patients that have heart disease risk, right? They shared risk factors like smoking. Leveraging the power of the electronic health record to try to kind of integrate that information so we find the right patient to notify. It's not appropriate to identify all patients because, again, some patients may have competing risk. And something as simple as an electrocardiogram that many of you can get from your Apple Watch can be used to diagnose inherited heart disease many years before it manifests. We're also interested in moving beyond the chest and the heart to the abdomen. Again, many abdominal CT scans are done each year for reasons other than to assess cardiovascular risk. But think about liver fat, visceral adiposity, tissue composition. All of these things are extremely predictive, and we have several projects around that. Now I'm going to shift gears and talk about the importance of digital inclusion. As we think about developing these tools, again, they have to help those that we're intending to help. So what are social determinants of health? Social determinants of health is really the conditions and the environment in which people live, learn, work, play, worship that really affect their health far beyond the small amount of time that they are spending with me in the healthcare system. These include things like the neighborhood and the built environment, economic stability, my favorite social determinant of health, education, because that stays really stable throughout the life course. Sometimes there's protective social determinants of health, like the culture or your community. That can be particularly important as an asset as we care for our patients. And a very small part of this, so we spend an oversized amount of effort and energy, is healthcare, where we all work. This is a very dramatic, and this is an aerial view. It's the same picture in Santa Fe, Mexico City, showing the difference in two communities, literally separated by a fence. Do you see that not everyone has the same opportunity to be healthy? When we make recommendations about going outside and exercising, you can see how the different communities have completely different possibilities. So it's really important to keep that in mind. And again, this is in the same area. When you look at the maps of poverty and heart disease in the United States, they can essentially be superimposed. They are one and the same. And as we think about technology and how we can use technology to improve quality of life, digital inclusion becomes a super social determinant of health. And again, they tie to every aspect we talk about. Digital literacy, access, things that we may take for granted like broadband access, connectivity. You may need additional training and support in certain communities. We've talked a lot about this in our healthcare system, is how do we engage our patients when they're not seeing us through devices, through connected care? And this is a term that I really like called health tequity. And this is really the strategic design and development and deployment of technology with the intention, a priori, to advance health equity. And in our cardiology ecosystem, this is really a perfect environment to think about all of these things, because cardiologists in general are very fast adopters of technology. We like things that make our job easier. We rely on technology for many of the things that we do to care for our patients. But how do we integrate it? How do we go from patient-reported data in a way that is useful for the clinician? Again, something that's great about the field of cardiology is that we work in care teams. All of us are part of a community. How do we support our patients? How do we still maintain an individualized care plan? And again, incorporate a lot of information that's coming in a way that helps us treat patients better, not just provide noise. So what are some barriers, and these are not specific to cardiology, but to really attaining the goal of health equity? A very simple one that, again, we often take for granted is just broadband access. This is perhaps our country's most inequitable structure. And of course, it changes by socioeconomic lines, but this is something that we cannot take for granted. Sometimes some of our patients have to go to public places to log in, for example, on My Health or My Chart and their Epic, and there may be privacy concerns, especially if they're talking about a sensitive topic. We assume that everybody owns a smartphone, and again, in general, they may, but they may not have the connectivity that other people have. And then as you get into more of the devices, the Apple Watches, the wearables, a lot of that starts dropping, again, across socioeconomic lines. When you're designing an intervention, sometimes I get people come to me after they've designed a product and they say, can you make it equitable now? I'm like, it's too late. No, we should have had this conversation at the beginning. And who is it intended to serve? Those individuals need to be at the table. And that's why all of our work really is informed by our patients. And finally, it's really when we think about AI as solutions, there's bias intrinsic in AI. And again, it's not the AI that's biased, it's our world that's biased, and the AI is training on biased data. Again, the maps of broadband access, the maps of cardiovascular disease mortality, we can see that it parallels it. Again, of course, it's a confounded ecological study, but very similar as we look at the poverty. One thing that our group has been very interested in is using telehealth as a way to reach patients that, again, may not be able to come to our Stanford main campus, particularly during the pandemic. But we studied this, other groups studied this across the country, and not surprising, there were many disparities in who was accessing telemedicine. Individuals who were older, women, non-English speaking, lower incomes had a harder time to really access these technologies. And a lot of times they just went to a phone visit or failed to have any care at all. And we saw that in the pandemic, preventive care really went down. So risk factors went out of control. And now we're still dealing with the consequences of this. As a practicing clinician, I saw heart disease complications that I had only read about in medical textbooks. They're so rare now because almost everybody kind of gets care earlier than that. So we're still dealing with the sequelae of this. But it doesn't have to be that way. So that's the definition of equity, is to really align the resources with the level of need. And again, this is a study that was done at Kaiser that showed that it just takes a little extra help. It takes a medical assistant to help virtually room patients into their telehealth visits to allow them to complete a successful visit. Again, a lot of opportunity, doesn't take a lot of extra work. Mass General Brigham, where I previously trained, ran a whole program called the Digital Care Transformation Program as part of a research project. Completely remote, algorithm-based cardiovascular management program for improving cholesterol, for improving hypertension control. Doctors were not involved in this. It was pharmacists, navigators, again, following guidelines. And what did they find? Significant improvements in cholesterol and blood pressure control. But what I thought was much more impressive about this study is that there were similar enrollment, similar improvements across race, ethnicity, and language preference. We can see here the reduction in LDL, that's the bad cholesterol for the full population, very similar across every group. And why? How did they do this? They did this because, again, they had different options. They didn't assume that everybody had a smartphone. Some people just needed a text message, a simple text message. The navigators spoke different languages. There was access to interpreters. One size does not fit all in this field. And when we design technology to be inclusive, we have to keep that in mind. There was a study that showed that taking into account, when we talked about the social determinants, the built environment will increase physical activity. So this app actually tells you where it's safe to exercise. It's still light, consider going to this park based on where you are, using geo-mapping. Again, increased step count, and people felt there was greater neighborhood social cohesion and safety. This study was done by my colleague Abby King at Stanford, again, showing that a virtual advisor, Carmen, kind of like an avatar, increased physical activity among Latino adults, and it was non-inferior, which was the trial design, to a human advisor. So think about the opportunities to scale interventions when we don't need an actual human involved. So again, we talked about that 90% of US residents own a smartphone, but do they have access to broadband internet? Around 20% of US residents own a smart wearable. So again, we start seeing things drop as the technology gets more advanced. But you can fix this, right? Think about how cost-efficient loaner devices can be if you're preventing hospital readmissions, if you're keeping people healthy. We really need to move to that. And again, in cardiology, it's a perfect field to think about this. We have all of our personal electronic health record data, the patient-generated data, EKGs, accelerometers, glucose level. It can help us triage the level of risk of the patient. But what's missing, and this has been missing for a lot of health tech interventions, is how do we close the loop? What happens? How do we keep people engaged long term? So finally, I have to talk about generative AI because this is a very popular topic in our research area of our group. So who's heard of large language models? Who? Over here. ChatGPT is the AKA. Okay, everybody. Okay, good. So large language models are an AI algorithm trained on billions of measures of unlabeled text using self-supervised or semi-supervised learning. It can understand, it can process, it can produce human language. So I want everybody, if you haven't used this, to try it today because there is some interesting things to gain. And it's here in all of our fields, and it's time that we think about how can we use this intentionally in medicine. So there's been a lot written around the potential for AI 3.0 or generative AI in healthcare, and particularly in our tripartite mission academic medical centers. We think about research, patient care, and educating our trainees. And also educating our patients. I would say community engagement is also very important. We think about research. One thing our group is really interested in is how do we align the patients enrolled in clinical trials to those that have the disease? And this is really diversity broadly defined, but they need to match. And this is pretty hard to do if you just tell people sign up for a study. Sometimes you have to look for individuals. Nigam Shah, who's a data scientist and their chief data officer at Stanford Healthcare, did a study showing that using large language models, you can go through all the clinical data that's stored as unstructured text and very, very efficiently find patients who meet criteria for clinical trials. Because our documentation as doctors, very little information is actually in the discrete fields like diagnosis codes, and those are very inaccurate. We may write some insights in our clinical notes that can help us identify those patients. When we think about patient care, and again, this has really been the focus of a lot of large language models in medicine, we can do something like translate and summarize documents for our patients. And I actually use this all the time when I'm trying to change something to a different language. Medical knowledge, and again, it can give you the right level for individual patients. This is a study from NYU that showed that something that we do after every hospitalization, we give patients a discharge summary. I think this is the most dangerous thing we do in healthcare. We say, we just did all these things to you, here's all the medicines, good luck. So that transition of care is really important. And how do we do that in a way that's understandable? We get so consumed with our jargon that we just are not communicating at the same level. So this, again, was a study that showed that the large language models was able to get that discharge summary and make it understandable and patient-friendly, again, with some caveats. We're interested now in doing this as one of our students, Eduardo Guerrero, for Spanish-speaking patients who are being discharged from our cardiology services. And how do we improve understandability, cultural sensitivity, and actionability? And a lot of this is not just language, but it's the reading level and how we're explaining things. And finally, in medicine, when we think about education, so all of our students are going to need to learn how to use these tools or have to engage with these tools for better or worse. And we have to be intentional in teaching them how to, when they're appropriate. Prompt engineering is something that we're spending a lot of time thinking about, is how do we use these models most effectively. We talked about this yesterday. We don't want to lose creativity or critical thinking. So how could we use these as ways to, but still maintain that curiosity that drives academic medicine. But I think the real value here is in personalizing education. A lot of our medical curriculum now, there's so much to learn, really happens asynchronously outside of the classroom. And there's been a lot of really interesting work showing that you can have cases, you can have patient interactions, vignettes that can really help our students become better physicians. But it's not just the education of our physicians or our trainees that we care about. We also want to educate our patients. There's a lot of misinformation out there. And can we harness large language models to create and curate accurate information? So we tested this, and this was an early version of the ChatGPT, and we asked a very, very simple question. How appropriate are ChatGPT recommendations for cardiovascular disease prevention? And what did we do? We created 25 simple common questions that we may get messages from our patients about. We posed each question to ChatGPT three times. This is an older version, just in case there were some changes. And then we had expert preventive cardiologists grade the response. Was it appropriate or inappropriate? And this is an example of a very common question that comes up in my clinical practice. I have muscle pain with a statin. What should I do? So if a patient Googles this, bad stuff comes out. They say stop immediately. It's also, you can really go down a rabbit hole. But this was a very reasonable, balanced answer provided by ChatGPT, which is essentially is don't stop it without talking to your doctor. There's different alternatives that you can try. Very reasonable. So again, these are the questions, and about 84% of them were appropriate. And the ones that were not appropriate, it wasn't because they were wrong, it's just that the data was too new or too nuanced. So that's always going to be the case in medicine, that there's not 100% answer for everybody. There is an art in medicine. And again, we talked about calcium scores. There's just some nuance that comes with clinical experience that just does not apply to all the cases. AI can also do this cute thing. It could write poems for you. So I had a patient that didn't want to take a statin, and I said, let me write you a poem about misinformation. And I have time, I'll read it. In the realm of the web where misinformation blooms, statins face slanders in digital rooms. Beware, say the myths, they'll make you feel ill. But truth's in the science, so let's get real. They lower the cholesterol and keep hearts on track, reducing the risk of future heart attack. So scroll past the chatter, the fear, and the fray, for evidence speaks louder than rumors that sway. So, yeah, beautiful, ChatGPT wrote it. And again, it's you can communicate, and you can say it. You do it in this, do this, explain 10 reasons, and give me another one. I don't like that one. So it's actually very good for this, and again, for patients to have a little bit more accurate information, because if you go down just the Google path, you will be wrong. And again, I'll end by saying that it's not that artificial intelligence or technology is biased. It's that we live in a biased world. There's discrimination in healthcare processes, unequal access. So the training data is imperfect. And our algorithms, our solutions are only as good as the training data, and they constantly change. I think for the coronary calcium algorithm that we talked about, we're in version 5. It gets better and better and better. And I was like, how could you have bias in something like an imaging algorithm? How can you have bias? And the answer is that there's different qualities of CT scans at different health systems. So again, it could perform differential. And you can see how your question can have downstream consequences. And there's actually a lot of legislation around this, and this is something, a topic for you as Congress, is how do you monitor AI? How do you make sure that there's algorithmic fairness, and is there frameworks to study this? And again, every algorithm really has to go through this, especially in the healthcare system. Again, I'll end by saying the definition of health equity is the state in which everyone has a fair and just opportunity to attain the highest level of health. And particularly in cardiology, particularly in prevention, we can do this. So in summary, artificial intelligence is a promising tool in cardiovascular disease prevention, but not a solution in itself. Diverse perspectives are needed at the design stage of tech-based solutions, not as an afterthought. And the real innovation is in moving from algorithms to action. Thank you so much for your attention. I am delighted to take questions.
If you'd like to enter any questions online in the chat, please feel free to.
Jesse? Oh.
I got the microphone. So thank you, this is fantastic.
Thank
My
you.
name is Rob McLeod. I'm a biomedical engineering
Wonderful.
faculty member. I've been engaged in cardiovascular research for 40 years, obviously more from the engineering side. And there's so many questions I have for you. I wish I'd been on your schedule. There's a couple I want to highlight. One is that compensation for medical care is not based on preventative success. It's based on procedural interventions. I have many colleagues who struggle with this because, like you, they want to see patients truly get better, and they realize they could do a lot more if they could intervene early, but compensation for that is absent or negligent. And I wondered sort of, this is a societal question, so I may be a good one for this audience.
Sure. I'm happy to comment. So I feel very strongly about that. I think our healthcare system is reactive. We have a reactive healthcare system. We're not preventive. We're not proactive. I'm a preventive cardiologist, and it's hard when you have that conversation with your trainees. There is no compensation for keeping people out of the hospital. Our system works by doing more procedures. And again, I'm lucky that I'm an academic physician and I have other things I can do to it. But if you're just trying to make a salary, you're right. Doing stuff to patients is not good if there's no evidence that it helps. And one thing that I didn't talk about is unintended consequences of this. So I think it would be a failure if this algorithm resulted in many more procedures for patients or many more tests. That is not the goal. But that could happen. And that's why I don't think that these tools can be deployed in a clinical setting without studying them. So I always say, always do this under the umbrella of research. And if it's not working or if we're not measuring it, let's kind of iterate on it. Because there could be that. And I think the healthcare system may look at it a different way.
So that functionally limits all the things you're talking about to academic medicine, which touches a tiny fraction of our population.
So I'll give you two other health systems where this is very, so Kaiser, which we work on, again, health systems that care about value. And the VA. So we actually do a lot of work with our VA hospital, and they have a VA health innovation. Again, you're incentivized to keep people healthy. The other group that we've had a lot of success with is working with employers, right? And again, employers are incentivized to keep their employees healthy and for them not to have costly admissions. But I don't want to get in trouble, but yes, I think that I could have a whole time. I completely agree with you, and I think our healthcare system needs some serious reform. But I think this is one way to identify people before I see them in the hospital. And again, COVID showed me that when you're not doing this, I'm seeing people with holes in their heart from a heart attack. You would never see that.
Yeah, and one final short question related to this. You mentioned AI 3.0, and I wonder if that was a Freudian slip to medicine 3.0 and Peter Attia and his suggestion that preventative medicine could not only improve cardiovascular healthcare, but a wide range of healthcare.
So it was actually from a JAMA paper that has a framework of thinking about AI. So AI, it's nothing that fancy. It's really algorithms and the progression of regression. So AI 1.0, we were talking about this yesterday, the IBM experiment with Blue, and then 3.0 is generative AI. So, but I could see the parallel structure there. Yeah, thank you. And a lot of my patients read that book.
Hi, Diego Islotlo. I'm a pediatric endocrinologist and former Chief Health Informatics Officer for Intermountain Health.
Oh, wonderful. Intermountain cares about this.
Yes. I'm very curious if you can expand a little bit more on the cultural side. You mentioned having patients and minorities included from the design side of things. You also touched a little bit about not just translating the words. Can you talk a bit more about what have you found from how do we culturally tailor the interventions you work on?
Absolutely, and I think, for people, and tech companies come to me all the time and say, can I get some advice? And they're like, we have this perfect algorithm for monitoring blood pressure. I'm like, who did you calibrate this on? The 20-year-olds that work in the company? That's not who needs a blood pressure device, right? So it's just step back, take a step back and say, who are you trying to help? If your tech solution is for healthy 40-year-old engineers, that's different. So I think you just have to have in mind, if, for example, so I'll give you, we're trying to do some stuff with remote monitoring in the hospital. The way to do that, and again, there's always a bias, because when you're trying to recruit patients, who has the time to do this? So I actually work with an external group called the National Minority Health Alliance, and they have a group of community patients and advisors, again, outside of academic health centers, which is a fair point. And again, these individuals are paid to sit in our focus groups. And again, we have their medical history. How would you interpret this? What's your perspective? And it's not going to be perfect because they don't live in this healthcare ecosystem. So one of my issues with identifying people with disease is, now what? Like, what if they don't have a primary care doctor? Again, the ER is the perfect place for this. There's so much undiagnosed disease that shows up in the ER. How do we get people in? So I think you need to have a partnership with the health system, and there are going to be only local solutions for that, because I think this algorithm actually is being used at 25 health systems. They're going to implement it differently in their health system. Have the patient perspective at the design stage, and again, our health system does this with focus groups, but I always ask, who's in those focus groups, right? Are they just the people who have time, who are retired, who are interested? Let's make sure we expand those voices.
So I have a question. Rich Linder, Chairman and CEO of Center. Work a lot with Bill Furon and Dave Lee.
Oh. Bill Furon, Fearless Furon.
Along with Benny Shaw and Elazar
Oh.
and the team out in Boston.
I know
also
them too,
with the U here, they've been wonderful. My question would be on using AI and digital ECGs for the diagnosis of CAD, what your thoughts are on that, and how that could impact CTFFR.
Great. So great question. And I think the CT, there's a whole discussion about CT and plaque analysis, which is fascinating. Now, the simpler the test, the more sensitive, but the less specific. So I think that, yes, I mean, EKGs have so many signs, and we've shown this for inherited cardiomyopathies, the voltage, all these signals that are kind of there, easy, accessible tests. We're just going to have to be prepared to deal with all the false positives and the anxiety of doing that. And again, if it's something that is an inherited condition like hypertrophic cardiomyopathy that really could be deadly, great, and that's why we screen athletes. Now, when we talk about something, again, even AFib detection, now, for that is you have to have a high pretest probability, otherwise your yield will be low. So I think it's a balance, but again, a low-cost technology for CAD, so then what's your diagnostic test after that? That's what I would ask. Is it a CT? Probably, and I think, and this is unrelated to this talk, but I'll say it because I think this, is that I think that we're going to move from functional testing, meaning stress tests, to anatomic testing, right? Like, let's look at the atherosclerosis, let's look at the plaque, and let's start to think about, let's act early before that plaque becomes unstable and causes a heart attack.
Imad Awad, Assistant Professor Emergency Medicine.
Oh, great.
I do a lot of research in cardiovascular emergency, and I always use traditional statistical analysis. And now I'm trying to integrate machine learning and AI. So just to understand, simple, straightforward question. So you said the application of AI is kind of more important. And I understand from the first section of your lecture that you used AI, using training data basically from CT and from patient record, and the main role of AI at that time, in that section, is to identify patients at risk. Is that?
No, so the training is based on paired, gated, so specialized heart scans, the ones you order in the ER with the contrast, but that are timed for your heart, and non-gated, non-contrast CT scans. So without contrast both, so the training set is paired. So again, we should have a perfect, the gold standard, what we use clinically, and then one that isn't. There was no patient data in that, so at all. It's just the CT, it's imaging.
Mm-hmm. And then, but the AI was able to, the main application of AI at that stage is to identify patients at risk, right?
Correct.
Thank you.
Yeah, and I think it's to identify patients who don't know. So for example, that's less useful if the CT shows there's a calcium score of 2,000, but the patient has a stent. Irrelevant, right? So I think the piece for the electronic health records, or more of the I would say clinical informatics, is how do we actually only notify those who would benefit? If the patient's on a statin, if the patient has had a bypass surgery, you're at risk. So you want to identify people who don't know they're at risk if it changes management, right? Not just for. Sorry, go ahead.
This is a lay question.
Yeah, of course.
I'm just curious, if you were to, watching COVID roll out was terrifying here in this state, watching people refuse to do things like wear a mask, refuse vaccines, and even in full-blown COVID cases, people refusing to take treatment and dying, and watching their loved ones die and sentencing them to die. If you were to be able to roll back the clock, given what you know about this kind of group thinking that you're trying to energize, how would we roll out information about a mass epidemic cure in the face of something like that? Because I think it happened very badly. And there's a lot of misperceptions that have killed people because of that.
Absolutely, and I'll say that there's a parallel. We actually did a analysis using online Reddit discussions. Again, not a platform that I use, but if you Google this, will come up. And we try to find themes for people, for statins, like how people feel about statins, again, cholesterol-lowering drugs. And there was a very tight correlation, which again, the AI, the nice thing about that is that we didn't have this hypothesis. It showed that the anti-vaccine, anti-COVID sentiment was linked to statins. They're like, you know what's even worse than a vaccine? Statins. In these discussions, and I was just like, so then to answer your question, how would I do this? Like, I think we have a responsibility to use these chat box to actually have accurate information. And again, I think a lot of it is bigger and larger, this misinformation, how it feeds. Now we have democratization of voices in social media. So we need people to have trusted voices. And I work a lot as a volunteer for the American Heart Association. And we did a lot of those, again, as a trusted community figure and voice. And then understand people's concerns. But yes, absolutely, I think you have a really important point.
I'm Seneca Moore. I'm an assistant professor for AI research at the University of Utah College of Nursing.
Wonderful.
And I'm really interested in the socio-technical aspect of implementing AI in healthcare settings. And I'm curious if you can talk a little bit more about kind of the patient perspective and how they felt with AI being involved in their care, and what were your impressions that you got from patients?
Great question. So I have learned so much, and I've had to do this kind of work, and I just take a step back and say, this is a team, and it's highly, highly collaborative. Because I don't have all the answers, but I've had to actually learn about qualitative research and work with implementation scientists and sociologists. Because what as a cardiologist, I'm like, this is a no-brainer. You have risk, start. But there's a lot of things that there's fears. There's all of a sudden you're giving somebody a diagnosis, right? And again, this is not you have a heart attack. This is you have a risk for developing a heart attack. Can we mitigate that risk? So we're doing a lot of work in now different versions of this. And how do we frame risk from this social cultural perspective? And how do we balance the efficacy of this scare intervention basically with still being actionable? So we're doing a lot of work on that now. And then the other question is, we spend a lot of time using the AI to create this personalized image. And we think that really motivates behavior. We're like, this is your heart. Our patient representative tells us, I'm not sure that makes a big difference. So I'm like, we're spending a lot of time on this. So I think that, again, this is why I'll take a step back and say the big theme is that everything needs to be studied. Because there's so many examples in medicine when we think something's a good idea, and it's not, or it has unintended consequences.
Hi there. So this is another lay question. So you mentioned the cardio calcium test. Is that the same test that some of us go out and just pay for that's like $70?
I'm glad it's $70 here. It's much more expensive in the Bay Area. Yes, so this is a test, and again, not to give medical advice, I'm gonna get in trouble, but this is a test that anybody can get. It's an out-of-pocket cost that ranges between, that's a good price actually, from $100 to $400, and anybody can get it. And I think you don't need a prescription, you could just get it by yourself. But I think what you do with that information is when you need a physician to prescribe you. But yeah, a very, very valuable test, absolutely. Especially, I think it's not valuable if you're already doing all the right things. It's not valuable if you're very low risk, but if you're intermediate risk, is an extremely valuable test because it can help decide, do I need to do more? And not just medicines, but also lifestyle. I think, Rich, you had a question? Jesse? Oh.
I did have a question.
Please.
I'm not a cardiologist. I'm not even a bioengineer like Rob. But I know there's a connection between cholesterol and heart disease, but you're talking about doing calcium tests. Cholesterol doesn't have any calcium in it. It's carbon, hydrogen, and oxygen. So what is the chemical mechanism that turns cholesterol into plaque in our arteries?
Oh, this is a good question. I love plaque physiology. So boring, but I can do it. I love this, all this jazz. Okay, so is that calcified plaque is actually good. I know this is crazy. It's a marker, but plaque that has calcified has stabilized. So again, this is not plaque that's going to flick off and cause problems. The plaque, and we used to think that heart attacks happen, you just get an artery blocked, but that's not how heart attacks happen. Heart attacks are unstable plaque that flicks off and blocks an artery. Now, statins stabilize plaque. One of the mechanisms that they do this is through calcification. So what you don't want, once you're on a statin, you don't want to get another calcium scan, because what will happen? Your calcium number goes up. And this is where things like CCTAs come in, that you can pick up soft plaque, which is actually more vulnerable plaque that can flick off. But that's expensive. That test has radiation. There's a lot of variability in that test. I'll tell you that I have patients, I see a lot of patients from Latin America who get their calcium scan in Honduras, same quality as Stanford, probably a lot cheaper, right? So it doesn't change what I do, whereas I think a CCTA is a little bit more nuanced. And for some patients, that's the right test. Again, not currently recommended for asymptomatic patients. And I can go way more into the plaque, but we can do that later.
Hi, I'm a data librarian here, and I was just wondering, when it comes to the data availability for the unstructured text used to do that large language model, how that data access worked, and if you think it could be applicable at other health systems, if that's something that could be implemented, or if the goal is more to expand the large language model that you're already working on.
Good, really good question. So electronic health record data obviously has a lot of privacy restrictions because it contains patient information identifier. So we have it within our cloud, and we don't share that data. We actually have, and most healthcare systems starting to have this, is secure chat GPTs, that you can run the large language models in our secure internal platform. Any data that we send out is de-identified, and again, does not include patient records or notes. When we think about, and we've done this when we talked about PCORI and things like that, like working with other networks, it's been difficult for unstructured data to have like a central repository, and I have not seen that yet. I may have missed it. For imaging data, there's excellent like national consortiums of data, right? And again, they have some affiliated structured data fields with it, ASCVD codes, but I haven't seen, again, there's some, but again, not the health system that feeds back into the health system. So one example of an openly available large language model is Clinical BERT. And that's trained on electronic health record from ICUs and health systems. So that's how we started doing some of our work with large language models. But secured chat GPTs work very well as well. And the models just keep getting better. Like I wrote an NIH grant. For those of you researchers know the pain of this. And they said, one of the feedback was like, this is Clinical BERT is outdated. And I said, by the time you review this grant, so it takes 2 years. So basically I just said, whatever the newest large language model is, we will use.
So hi, I'm interested in your algorithm on cholesterol. I think based on these scans, my background's diagnostic imaging. And I guess take a healthy patient, healthy weight, good diet, all the things, high cholesterol. Are you recommending a statin or a scan or something different?
That's a great question. It's a little nuanced, and again, I won't give medical advice, but in general, if you want to, the lower the LDL cholesterol, it's causally, like the lower that number is, the lower your risk of heart disease. And again, families that have had mutations in LDL cholesterol synthesis pathways have very, very low rates of heart disease. If the patient is, for example, has very, very high cholesterol, like genetically high cholesterol, you just have more exposure to LDL, then you should just take a statin. There's no reason for a calcium scan. There is a disutility, which I recognize in taking a pill every day. And again, for somebody intermediate risk, I'll say the calcium scan can also de-risk you. So if your calcium is 0, that is very helpful information. Again, I think of cholesterol more as a way to reduce risk, not necessarily an absolute number, except for individuals who've had heart disease already. So it depends. I mean, that short answer is and I think the other purpose of a calcium scan is really to motivate. Again, we're not talking about take this pill one time and be done. We're talking about lifelong pill. So if you see, hey, I have plaque in my arteries, that changes your calculus, and it really motivates adherence, and it helps. And I pull up the scans in my patient. And I'll pull up any scan, honestly. Like I just say, I see atherosclerosis. Let's deal with that before it becomes a problem. Jesse? Jesse, am I in trouble for all this?
Any final questions?
Can I just, I'd
Sure.
love to hang another one on this.
Sure.
Because as a preventative physician, you have the unenviable task of convincing people to take care of themselves. And you mentioned one motivational exercise you do, but can you suggest some other ways to motivate people to do the obvious things that we all know are so beneficial to our health generally? Exercise, of course, being the one that's all over the media now, but doesn't seem to be influencing huge numbers of the population.
Absolutely. So I think I have, a lot of my patients have a pretty bimodal distribution. I see advanced coronary disease, and then I see a lot of inherited cholesterol disorders. And people who are willing to do anything but take a medication, like anything. and again, we see, and I think people just want the feedback. So one of the reasons that a drug like Ozempic is so popular, people would take that in their eyeballs. They'd be happy to take that because there's so much, you get feedback, right? And so I think having frequent labs, so I think markers of success, especially for my patients that are engineers, like your LDL has come down. This is the marker. These are the targets. That can really help people. Weigh yourself every day. I often, like we talked about social determinants of health, the family is a great motivator. Like, do you want to be around for your family? You have this risk factor. Let's make sure we screen your whole family, and they can do something before they have an event. So I kind of bring the whole family unit, and when you change your behavior, you're not changing just yourself. You're changing your whole kind of ecosystem, and it's contagious. Bad habits are contagious. Moving to California has certainly made me healthier because my environment is healthier, right? Thank you for that good question. Thank you.
Well, please join me in thanking Dr. Rodriguez for this really, I think, thought-provoking and insightful. And thank you all for the excellent questions and engagement. I love to hear the questions of these lectures and hear what people are taking out of this. So thank you to the Goulds, and thank you again, Dr. Rodriguez.